Good evening, everybody in the region. Today with you is Professor Husam Salah, Professor of Neurology, Cairo University, and Director of University's Hospitals. I'm sharing this session together with Dr. Maria Khan. She is the neurology specialist in Rashid Hospital and has great efforts in stroke in Emirates and in the whole region. And we have Dr. Elyar and Dr. Fawaz, our person life. First of all, I would like to thank you all, and it is indeed my great honor to welcome you all to the 10th episode of the successful series of MENASO Cerebrovascular Grand Round Webinar, organized by the MENA STROKE Organization. It's endorsed by the World Stroke Organization and American Stroke Association and supported by BI and Medtronic. MENA Stroke Organization is a wide, non-profitable organization committed to a vision to reduce the overall stroke burden in the MENA region. Organizing the webinars, MENASO contributes to the comprehensive education to help the entire stroke community. The Cerebrovascular Grand Round Webinar is a unique platform that provides comprehensive education about stroke and its latest treatments and management. We will have at the end of the session the Q&A session, remarks, and it will be an interactive session that we will have a dedicated question and answer session at the end of the lectures. We encourage all the attendees to post their questions about the topics in the Q&A box. I will start by introducing Dr. Elyar Sadeghi. Is an interventional neurologist. He's the head of the stroke unit care at Untitled Hospital in Tabriz, Iran. He's an associate professor of neurology, Neuroscience Research Center, Neurology Department, Imam Riza Hospital. He's also the member of Stroke Scientific Committee in the MOH, Assistant National Coordinator, SIDS International for Iran, Angels Coordinator in Iran. He has academic degrees in the Doctor of Medicine, in the Intervention of Neurovascular Neurology by 2016. He has more than 50 years of experience in the field of neurology. He's also an author of more than 35 key publications. Our topic today will be about stroke challenging cases from Iran. I welcome you, Dr. Elyar. It's my pleasure.
Hello, everybody. Good evening. Thank you, Dr. Husam, for your nice presentation. I have no disclosure for my presentation. I'm going to present two challenging cases from Iran. And for the sake of time, I will present these cases not in detail, just I will point to important information so we may have enough time at the end of the session so we can discuss about the cases, and any comments are greatly appreciated. My first case, she was a 60-year-old lady presented with sudden onset headache. Her physical examination was quite normal. On past medical history, she had two important points. She had two cardiac surgeries. First, she had a prosthetic mitral valve replacement 35 years ago, and second, another surgery, and she had prosthetic aortic valve replacement 11 years ago, and she was on warfarin. On the other hand, she had idiopathic thrombocytopenic purpura, ITP, and she was on azathioprine and prednisolone. Her lab at the first day of admission, her INR was 2.5, and her platelet count was 28,000. She also had atrial fibrillation. These are her CT scan images from the first and second day of the admission. As we all can see, there are some subtle hyperdensities at the posterior fossa. It was the blood below the tentorium and above the cerebellum, and she was suffering from this subtentorial subdural head hematoma. We asked for some reconstruction images, and I do apologize for the poor quality of the images, because at that time our Neo scanner was exclusively working for COVID patients, and this reconstruction was done by an old machine. And as we see by these points, the patient had the hematoma at the inferior aspect of his infratentorium. Okay, this was our first challenge. Our first challenge was when to reinitiate antithrombotics. We had a patient who had an acute RCH on one side and was very high risk of thromboembolic events on the other side, since she had two prosthetic cardiac valves and an AF cardiac rhythm. As we all know, in the literature, there are really rare information about this question, and actually no RCTs has been done directly answering for this question. I believe this is the most powerful evidence we have in the literature to answer this question, presented by Dr. Kuromatsu. Dr. Kuromatsu, you may know, has lots of articles and manuscripts in this regards about how and when we can initiate antithrombotics after various kinds of CVA. They published this paper in 2018 in European Journal of European Heart Journal, and they did a nice job. They gathered all patients from 2 retrace trials, and eventually they could gather more than 160 patients with mechanical heart valves, which all of them also experienced intracranial hemorrhages. And by doing outcome analysis of these patients, they could reach a very practical figure that we use mostly to treat our patients. Based on this very nice figure, if a patient has mechanical cardiac valve and also suffers of intracranial hemorrhages, we must not start anticoagulation before that 6th day, because it significantly increases the rate of hematoma expansion and remobility. On the other hand, we should not delay our anticoagulation to any time after than 13 days, because it causes significant increase in the rate of thromboembolic events. So the best time to reinitiate anticoagulation after the ICH in these patients who have mechanical heart valves is between day 6 and day 30. Okay, now another question comes into mind, and it is when to initiate after 6 days and when to initiate after 13 days. If our patient is in a very, very high risk of thromboembolic events, like patients who have 2 valve replacements, like patients who have old generation valves, or they have concomitant AF, they are in a very high risk of thromboembolic events, and we may start anticoagulation after 6 days. But if our patient is not in a very high risk of thromboembolic events, like she has just 1 aortic valve and it is the new generation valve, maybe it's better to wait until 13 days. So based on these data, for our case, we started anticoagulation with heparin on day 7, and after 5 days, we started warfarin. Her platelet count was around 500,000 per microliter, so we started IVIG to rise her platelet count. Platelet count transiently rose up to more than 200K, but again decreased to less than 100 within a few days after IVIG. But we faced another problem at the 16th day of her admission. She complained again of another attack of headache, and we asked for a controlled CT scan. As we see at the control CT scan at 16th day, unlike the first CT scan, the blood is not exclusively at the posterior fossa. This time she has intracerebral hemorrhage at his cerebellum, also the blood at the interhemispheric region, and some foci of subarachnoid hemorrhages. At the time of second bleeding, she was on warfarin. Her INR was 1.6, and her platelet count was 85K. Anticoagulation effect reversed with vitamin K and FFP. We asked for further diagnostic workup. We asked for full panel coagulation tests, which came in normal. We asked for vasculitis tests, which were normal, and we did the digital subtraction angiography. At digital subtraction angiography, we could find an early filling defect at her right parietal, and we concluded that there is an AVF, dural AV fistula, from distal branch of the middle meningeal artery to the cortical veins and to the then eventually to the suprasagittal sinus. And since the location of blood in this patient was far away from this lesion, we decided to ignore this lesion, and we thought that this lesion was an incidental finding. So we faced our very important and the second challenge: what to do now. We had a patient who really needed to be treated with a vitamin K antagonist, but on the other hand, she had her second ICH in the less than 3 weeks, while her INR was not even in the therapeutic range. Her INR was 1.6, and she also had thrombocytopenia. We had 3 choices and we had 3 options. Our first option was to do a cardiac surgery and replace the patient's mechanical heart valve with the biologic valves. With this surgery, 3 or 4 good things could happen. First, we could significantly decrease the risk of thromboembolism at our patients. Also, we could keep INR lower with the biologic valves. Also, there would be no need to aspirin anymore. Unlike patients with mechanical valves, patients with biologic valves, they do not need aspirin. And also, later, we could change warfarin to neural anticoagulants. And as we all know that the rate of intracerebral hemorrhage is much lower with neural anticoagulants in comparison to warfarin. But again, our patient has another problem, and she had an atrial fibrillation rate. So this was another risk for thromboembolism in this patient, and what we could do for her atrial fibrillation rate. The answer is we could occlude the appendage of the left atrium on the same cardiac operation. In this regard, there are plenty of good articles and good evidences in the literature that the closure of the left atrial appendix decreases the risk of thromboembolism in these patients in future. And recently, a very nice paper published, the LAOS 3 clinical trial. A couple of months ago, they published a very, very nice paper. And at this paper, they showed that occlusion of the left atrial appendix in patients with AF significantly decreases the risk of thromboembolism in the future in these patients. So by doing just one surgery, we could change the patient's mechanical valves with the biologic valves, and also at the same operation, we could occlude the patient's left atrial appendix, and by doing this, we could achieve a very good decrease in the risk of thromboembolic events for the patients in the future, and this was a good option for the patient. But unfortunately, at the meeting, our cardiac surgeon said this would be patient's third cardiac valve operation, a TRIDO, and it's possible, but we will not accept to do the surgery because the mortality rate would be very high. Our second option was to just leave the patient with no thrombotics because maybe she would experience the third hemorrhage, and later on, if the platelet count raised above 100,000, then maybe just we could continue with aspirin. But this option was too conservative and it was too risky for the patient. The risk of thromboembolic events in this patient was very high, and we could not just leave the patient without any thrombotics. So we moved forward with our third option, to do something for the platelet count, and hoping with higher platelet count, bleeding won't occur again. And that's why we started rituximab for the patients. And while patient's platelet count was over 100K, then a splenectomy was done for the patient. Actually, this was another challenge for us with these patients because none of our surgeons and anesthesiologists were not accepting to do the surgery for the patients. But finally, a splenectomy was done on day 44 after the admission. It was 28 days after the second bleeding. Meanwhile, our patient was just on prophylactic doses of heparin. Namely, she was receiving 5,000 units of heparin subcutaneously twice a day, or in some days, 3 times a day. And also, we were doing serial echocardiographies for the patients to monitor the patient's cardiac condition. And even she had spontaneous echo contrast just before the surgery. And we know SEG is one of the major important risk factors for embolism in the upcoming days. Fortunately, we were so lucky, thanks God. Spectomy was done for the patient without the complication, and we were lucky, and the patient was very lucky. Later, after the surgery, platelet count rose, and IV heparin started 4 days after the surgery, and then warfarin started a few days later. She was discharged after 64 days of admission with INR of 2.6 and platelet count constantly over 200,000 per microliter. I had a chance to recently visit this patient 4 months after the admission. She was completely fine, no signs, no symptoms. Her platelet after discharge gradually rose up to near 400,000, and her INR was 2. Okay, but another question still remains, what to do for the patient's dural AVF? Should we proceed with embolization of that AVF or just wait and monitor the patient? Although while she was admitted, she denied any procedure. Okay, this was my first case. Let me please present my second one. Then we will have enough time, inshallah, at the end of the session to discuss about the cases. My second case was a 38-year-old woman referred with headache and seizure. She had progressive headache since 5 days ago. On admission, she was comatose, had left-sided weakness on noxious stimulation. She had taken just 4 pills of OCP, oral contraceptives, and she had no history of COVID-19 infection or vaccination. At her first CT scan, as we see, she had prominent hydrocephalus, parenchymal edema, and we can see the dense sign here at the location of the transverse sinus and here at the location of straight sinus. We asked for MRI. At MRI, T2 and FLAE images, she had extensive T2 hyperintensities at bilateral basal ganglia and also at the periventricles, which was suggestive of deep vein thrombosis for the patient. At the gradient echo sequences, we could nicely see the clot here at the straight sinus, also at the Galen vein, at the internal cerebral veins, and also at the Rosenthal vein. We asked for brain MRI, and these are the images of time of flight MRVs, And at MRV, we cannot see the straight sinus here, and none of the deep vein of the patients. Also, we can see very hypoplastic right transverse sinus here, but the left transverse sinus and the left sigmoid sinus are absent. So we were facing a patient with a deep venous thrombosis with severe symptoms. We started intravenous anticoagulation with low molecular weight heparinoids, namely with enoxaparin, 80 milligram twice daily. Seizure was controlled with drugs, and we started acetazolamide and topiramate for her ICP to control the intracranial pressure. After 48 hours, level of consciousness decreased further, and there was no response to medical treatment. GCS was less than 8, and she intubated on the 3rd day. We asked for control CT scan, and at control CT scan, as we can see here, the hypodensity of the periventricle was more prominent, and also what was very obvious that she was suffering from a very severe hydrocephalus with periventricular edema. Our challenge was what to do next for these patients. We knew that these patients are not going to have a good outcome, and based on this case, predicting the prognosis of CVT, she predicted to have poor outcome. We have 2 very good predicting scales for CVT patients. They're very important, and the old one presented by Dr. Fellow since 2009, the famous CVT risk score, which is a 9-point scale. And recently, we have the CVT grading scale. It has been published since 2018, and it is a 13-point scale that predicts the outcome of patients. If we want to just compare these two scales, CVT score is better at predicting good outcomes, and CVT grading score is better in predicting mortality. Our patient pointed 9 at CVT grading scale, and as we see here, if the patient's point was 9, the mortality, the expected and the predicted 30 days mortality rate was about 60%, and the poor outcome was more than 90%. So we were thinking of doing something for the patient so we can change the outcome for the patient. How about the intravascular intervention? We do just ask for the DSA and intervention and do the mechanical thrombectomy or direct intravenous thrombolysis for the patient. As we may know, aware of the TUAC trial published in 2020 by Professor Coutinho, the TUAC trial was a very interesting trial, and this trial showed us the CVT patients who have poor prognosis based on those scales. If we ask for endovascular treatment will not result in better prognosis of these patients, and it will not improve function outcome at 12 months. And this is why, so far at guidelines, interventional treatments for CVT patients is not recommended. Of course, these patients are good patients to be recruited in clinical trials, and if we have such a patient, it's better to recruit these patients in clinical trials. Okay, we move to our second choice. As we look again, if we look again to patients, the control CT scan, her hydrocephalus was getting worse, and we thought that maybe her ICP is very high. So we decided, and I insisted to our neurosurgeon, to insert an external ventricular drainage for this patient. And the operation was done at the 4 days after her admission. Of course, after changing enoxaparin to unfractionated heparin. What we did, we held heparin for 6 hours before the surgery and restart heparin again without bolus dose 8 hours after the surgery. 1 day after the surgery, she lost all her neurologic reflexes, including brain stem reflexes. Control scan was done 1 day after the surgery. As we see, she developed very extensive intraventricular hemorrhage and very severe parenchymal edema, which was the reason she lost all his neurologic reflexes. And unfortunately, we lost our patient on 6 days after the admission. There are 2 debates regarding these patients. Was evidenzation at all a good decision for this patient? Since any procedure needs withholding treatment with anticoagulation for hours, and we know that anticoagulants are the main system of treatment for CVT patients, and in this patient, we hold heparin for 14 hours. Was there any indication for or any benefit from EVD injection for this patient? These are debates and questions about this patient. And another debate was, maybe we restarted anticoagulation too early after the surgery. We started heparin 8 hours after the surgery. And maybe, just maybe, we needed to wait a little more after the surgery to restart the anticoagulation. As maybe you remember, there was a very nice webinar 2 or 3 weeks ago about CVT, and Professor Coutinho and Professor Sapostic, the great experts in the CVT, they were in that meetings. And I asked a question, if you have a patient with CVT and that patient undergoes the compressive craniectomy, when you are going to restart anticoagulation after the surgery for your patient? And Professor Coutinho said, we don't know by sure, but in practice, for most patients, we wait at least 48 hours after the surgery. On the other hand, yes, we know that evidenzation is a much less invasive procedure for patients in comparison to the compressive craniectomy, but maybe we needed to wait more. And the reason that our patients had a very extensive IVH was because we started anticoagulation very early. Okay, as a take-home message, for patients with mechanical heart valves and ICH, use 6 13 rule to reinitiate anticoagulation. In patients with AF, closure of LA appendix during cardiac surgery significantly decreases the risk of thromboembolic events. We reviewed the CVT risk score and CVT grading scale. And in patients with CVT who undergo invasive cranial procedures, maybe we should not rush to restart anticoagulation. Okay, that's it. Thank you for your attention and patience. Any comments will be greatly appreciated at the question and answer session. Thank you so much.
Yeah, okay. So thank you very much. Those were very interesting cases and very challenging as well. We'll move on to our next speaker, and then we will be happy to take questions. I see a lot of good evenings coming from our audience. We have close to 880 people currently participating. So put your question in a box, and we will take them at the end of this lecture. Okay, so our next speaker is Dr. Fawaz Al-Sharif. Dr. Sharif, consultant interventional radiologist. He's currently working in Jeddah city, and he's covering 8 major hospitals. He is a member of the Society of Radiology, Swiss Society of Radiology, European Society of Radiology, the Pan-Arab Interventional Radiology Society, the French American Radiology Society. He holds a huge a number of to his name, and he has about 20 years of experience in the field of neurology, and he has authored several key publications. Thank you, Dr. Fawaz, for joining us today, and over to you.
Okay. Thank you, Dr. Maria, for this nice presentation, and thank you for the invitation. Today I was asked to present flow diversion for acutely ruptured cranial. I have a disclosure, consultant for Medtronic and intervention. Today, my agenda talking about aneurysm introduction for junior audience, because I invited some of my junior colleagues. Next step to flow diversion technique. Some challenges, especially in acute case. Talking about some evidence-based medicine regarding flow diversion in acute phase. And I will share with you 2 challenge cases. So, in brief, cerebral aneurysm is abnormal dilatation of intracranial artery, can be saccular, pseudoaneurysm, fusiform, or blister-like. Size varies from to more than 25 meters. Prevalence is 2% population, and the percentage is the type. Next. This is the histopathology section of the aneurysm. As we know, the artery wall consists of layers, intima, media, and adventitia. What we can recognize here, the intimal layer is thinning, and it can be disappeared. And we rest with media and adventitia that it will blown till with rupture. Next. Location, most of the aneurysm is located in the circle of Willis. In the ICA, it's 42%, MCA 30%, in ACA is 24%. Next. And the most major factor that causes inflammation of being a female smoker, hypertension, alcohol consumption, or conservative dyslipidemia. But we can really accuse the hypertension and the hereditary of the disease and of the wall of the artery itself. Next. So simply the gold standard of treating the aneurysm is by coiling and classically by clipping, but by the endovascular coiling in the acute phase is the gold standard. And we can do as well. Can we go to the next slide? And we can do fluid remodeling by balloon assisted coiling. Next. As we can see, we can just put the catheter inside the aneurysm and inflate the balloon in front of the neck. We coil the aneurysm. Next, please. The other modality is doing assisted coiling. We either go through the struts or draining the catheter and we coil the aneurysm. Next. The newly coming since 2007 is the Virgin. It depends on the porosity of the stent itself and the mesh of the stent and the scaffolding of the stent. We redirect the flow from the artery going to the aneurysm, go to the supplying artery. That will exclude the aneurysm and we get rid of it. This is in summary the modalities of treatment and coming in the market. Next slide, please. The intrasaccular flow diversion. It's like a basket. We put it inside the aneurysm. It will catch the blood and doing thrombosis and redirect the flow away from the aneurysm itself. As we can see in this case, basilar tip ruptured aneurysm, and this is the intrasaccular flow diversion, and this is immediately after the treatment, and in the 6 months follow-up, we can see the flow diversion completely away from the aneurysm. Next slide, please. So the endovascular treatment of acute ruptured aneurysms proven itself since 2001 when we published in Lancet the superiority of endovascular treatment over the clipping, and the history started from there, and the history changed for the treatment of the next slide. So, as we can see, in this case, it's a 12-year-old male patient who came with a headache. The CT shows the subarachnoid hemorrhage, and we can appreciate small saccular aneurysm of superior cerebellar artery. And as you can see, this is the aneurysm. This is after coiling. We see the angiogram has already the aneurysm is outside the circulation. Next. And even if it was bigger than this, like in this case the IC become aneurysm. We coiled it, packed it, and at the end we exclude from the system. This is the simplest way to do to treat the intracranial ruptured aneurysm. Next. Sometimes it's not as simple as that, like in this carotid terminus aneurysm with Mickey Mouse head. We can appreciate here we treat one sac and we go other sac, and then we did a Y stenting to complete occlusion of the aneurysm, that leads to a complete exclusion of the aneurysm from the circulation. And this is a 28-year-old female presented with Glasgow coma 14 and acute bleeding. Next. The subject of today is fluid diversion in acute phase. Fluid diversion, it's like in this case, we put the fluid diverter stent, and we can get rid of the aneurysm immediately after the procedure. Next. So this is another case with ophthalmic artery aneurysm. We can see here the stent fluid diversion. 6 months follow-up. We can see the aneurysm is totally gone with preserved ophthalmic artery. This technique can preserve the side branch from get occluded in most of the case. Next. And we can add to this technique some coiling, like in this lady. She presented with 6 palsy. We enhance the immediate thrombosis by adding some coils, and we did the fluid diversion of the initial aneurysm. And this is 6 months follow-up. You can see the aneurysm is totally outside circulation. Next. Next. Okay. This is what we need to see at the end of the stagnation of the contrast inside the aneurysm. So, if we see this at the end of our procedure, that means it will do the effect of the treatment at the 6 months follow-up. Next. Sometimes we treat multiple aneurysms, like in this lady, 48-year-old female with left sixth palsy. We can appreciate here ophthalmic aneurysm and cavernous one. We did telescopic fluid diversion, and this is 6 months follow-up. And this is what we need to see at the end of the procedure. The stagnation of the contrast side the aneurysm. So after 6 months, we can get this result, which is the optimum result. Next. The same lady has contralateral ophthalmic aneurysm, treated 3 weeks after. So we can see immediate occlusion of the aneurysm in this case. Next. The new technique is the intrasaccular fluid diversion. The first case in the Middle East, in Jeddah. We can see this is the aneurysm. We appreciate the MCA and this MCA bifurcation in two. The only way to do this is by clipping or by stenting. Why stenting in these branches, which is too difficult because of the acute angle. Putting a whip or intrasaccular diversion device will save the 2 branch and get rid of the aneurysm. Next. So, complication in general of the intracranial aneurysm treatment, we can have a complication size, thrombosis due to the catheter, sending ambulance, venous direct dissection, stent occlusion, or severe hemorrhage due to the antiplatelet or anticoagulant that were administered at the time of the procedure. And there is some percentage of recurrence. So, in our talk today, what we are saying is that these three points: the thrombosis, stent occlusion, or severe hemorrhage due to antiplatelets. Next. We do variable, depends on the schools, follow-up. In our area, we do conventional cerebral angiogram at 6 months and 3 years. Some centers do by MRA, but we do by conventional cerebral angiogram. Next. So, regarding our talk today, doing the fluid diversion in acute phase, it's been supported by multiple articles and meta-analysis of 20 centers shows the safety of this technique in acute phase. Henkes and his colleagues in Stuttgart did a series of 45 patients treated in acute phase during the first week of subarachnoid hemorrhage, with good outcome comparable with the elective cases of if the patient has an EVD, external drainage, they go with a dual antiplatelet. Their regime is giving aspirin, ticagrelor, prasugrel, or clopidogrel, and if the patient doesn't have external drainage, they put one if it is Hunter Hess 3 or 4 or Fisher 3 or 4. And then after loading the patient, they load the patient and then they put the flow diverter. In our region, we load the patient by aspirin and ticagrelor. Next. So this is the case, very challenging case that I want to share with you. She's a 32-year-old female presented with a headache and vomiting. When they did a CT scan, we can see a partially thrombosed aneurysm with the filling in the aneurysm. And when we did the CT angiogram, we see the filling of the aneurysm by the contrast. Next. So this is very challenging. So when we went through the circulation, we can see the occlusion of the basilar artery, and at the same time there is in the aneurysm. We went to the anterior circulation, we see the PCOM artery and the occlusion of the basal. So in this case, it's whether we go destructive or constructive. So in destructive phase, we were really afraid of extension of the thrombosis through the basilar and causing harm for this patient. She's a young, and she only presented by headache and vomiting. So what we did next, we went through the anterior circulation and we go retrograde because the anterograde fashion couldn't pass the aneurysm. So we went retrograde, and this is the lateral view. We can see the flow diverter through the dissecting part, and this is AP. Next. And this is the final run. We can appreciate that the recanalization of the basilar artery through the posterior circulation, and some dissected part here. Next. This is another case that I did it last week. 75-year-old male presented by headache and subarachnoid hemorrhage. As we can see, This is a fusiform aneurysm, and with a sacral aneurysm at the side. So this is the only way to do this aneurysm is just whether to put this scapula or to put a fluid diversion. So we do the diverter after loading the patient with the Brilinta 180 milligram and aspirin 500, and we end by stagnation in the aneurysm, and the patient is already at home. Next. So, in conclusion, a fluid diversion is an alternative strategy for management of acutely ruptured aneurysm with high rate of occlusion and acceptable complication rate. Next. Okay, thank you for listening and attendance, and sorry for the audio. Thank you.
Okay, thank you very much, Dr. Fawaz. Unfortunately, I mean, the audience kind of struggled a bit because there was a lot of echo, but thankfully there were a lot of images in your slides, which I think were quite self-explanatory. I think, again, there are two devices on somewhere. We'll move on to the Q&A session, and I'd like both our speakers to sort of join me through this. And I'd request the audience, who are now close to 1,000 participants, to please put their questions in the Q&A session, and we'll try and address as many of them as possible. So for Dr. Elyar, I think the first few questions, I'll start with you. There's a question that why was mannitol not considered for reducing the ICP for the CVST patient?
Thank you very much, Maria. That's a very nice question. I think my voice have echo too. Is it better? Yeah. I'm not sure, Maria. May I proceed or just wait to fix something?
No, it's okay. Please go ahead.
Okay, thank you. Yeah, actually, we start and hyperstalling for these patients and for all patients in similar conditions. And although it is not recommended in the literature, in some patients with severe increase in intercerebral pressure, we sometimes use mannitol and hypertonic together for our patients. And she has been treated with mannitol and hypertonic, and unfortunately after 2 hours, she did not have any response to medical treatment, and the situation was getting worse. And that's why we were thinking about to do something maybe more invasive, but to do something for the patient.
Okay, and another related question is, I think mannitol would have prevented the hydrocephalus developing.
I'm sorry, Maria. I'm afraid that I did not correctly. Would you please ask again?
Okay, I'm sorry. I think the sound system is giving us a lot of trouble today. The question is, would mannitol have prevented the hydrocephalus from developing? You're mute.
Yeah, I'm doing my microphone mute so I can hear you better, but I'm afraid that I didn't understand the question again. Would you please repeat it?
So the question is, would mannitol have prevented hydrocephalus from not
Yeah. Thank you for the. Yeah, I get it now. Actually, not sure because at the repeated CT scan after 2 days, the hydrocephalus was getting worse, and the patient was under treatment with mannitol. I don't know if we didn't give mannitol to the patient, what would happen, but we believe that at least in some part mannitol was effective, and it helped patients at least, not too much, but it was helpful for the patient.
Okay, thank you. So another question that I'm interested in is deep venous thrombosis something you see quite commonly, or is it one of those rare things? It usually turns out to be quite devastating, but in our experience at least, it's not one of the common presentations, but I'd love to hear from your center, your experience.
Thank you for your comment. Actually, versus to me, and it serves me. I don't know if you can do for that. Anyway, I'm going to answer your question. CVT for sure is not a rare condition in Iran. In our region, we are seeing lots of patients in Iran, and in our city Tabriz, the population of 1.5 million, we can see at least 80 CVT patients a year. And I'm quite sure that we are not visiting all the patients, and the total number of patients, I think, is much. Actually, we are the main referral hospital for these patients. And regarding to deep CVT patients, we have a registry, and we have the exact number, but I'm not sure. But just as a guess, I think maybe 15% or 20% of our CVT patients are deep CVT patients, and for sure these patients have worse outcome in comparison to other superficial or the suprasagittal or transverse venous thrombosis. But the very most important in treating these patients is the time. In our experience, if we could diagnose the patient soon and start the treatment soon, with intravenous anticoagulation, the patient might very good recovery, and sometimes they came back from a coma situation, and I have patients that they are completely fine now, but while at the hospital, their situation was bad, they were comatose, they were intubated, and so on. But in some patients, unfortunately, especially because CVT presentation is subtle, the patients have headache and these things, which are not very specific for the patient that's having a very problem. These patients are usually referred to us, and the treatment starts very late. And I think this is the very most important factor in prognosing of these patients, and treating late patients is equal to poor outcome.
Okay, thank you. I apologize again to the audience for the echo in the sounds. Unfortunately, we're struggling to kind of correct it today. I'll direct my next question for Dr. Fawaz. So the question is regarding coiling when there is vasospasm present. How difficult is it, and would you still attempt it in a situation where you see severe vasospasm? Dr. Fawaz?
Yes, very excellent question. For this patients, actually, we have a tendency to treat them as soon as possible, as the guideline says. So we know that the vasospasm starts at day 4 and can peak till day 7, and will held it till day 14. So if we can catch it earlier, it's better. But if the patient has a vasospasm, we can still do the coiling, and it's difficult. We ask the help of propamine or nibutibine intra-arterial to do some dilatation of the vessel before doing the coiling. And sometimes we do balloon angioplasty if it is severely spastic.
Okay, thank you. Next question is also directed at you. The question is regarding antithrombotics. So you showed us the flow diverters. What kind of thrombotics is requiring procedure like this?
Can you repeat the question just in short?
So is there a need for antithrombotics like aspirin or a dual antiplatelet for a flow diverters, the kind that you showed us?
Yeah. So we built our experience from the cardiologist because they are earlier than us. So they started in the 70s. We started loading the patient by Plavix and aspirin. 600 milligram Plavix and 500 milligram aspirin. And then we converted to the new agent antiplatelets. Personally, I use Brilinta, which is the ticagrelor, 180 milligram and aspirin 500 milligram. I hope that it was clear the dose. 180 milligram Brilinta and 500 milligram aspirin. And we assume that it works in the coming 30 minutes before the deployment. And we asked as well intravenous 5,000 international unit of heparin. This is our protocol.
Okay, thank you. Just one last question from Dr. Elyar before we close the session. So there's a question from the audience that wouldn't it be better if we use low molecular weight heparin for the initial 48 to 72 hours after surgery, and then therapeutic anticoagulation?
Yes, Maria, thank you for the comment from the audience. Yes, this is one of the approaches that lots of experts and experienced stroke neurologists do for CVT patients, and they just continue with subcutaneous and subtherapeutic prophylactic dose of anticoagulation after any invasive procedure for CVT patients, at least one or two. And then they start to the flow of anticoagulation. And maybe this is the wiser way to treat our patients. But I thought myself at treating that patient, EVD is not that much invasive for the patient, and really was needed to be treated with anticoagulation, and that's why we started with something like 8 hours after the procedure. And yes, I might think maybe we should wait a little more, and if I have another patient like this, for sure, I will just start the prophylactic dose of anticoagulation for at least 1 day for EVD and for at least 2 days for the comprehensive craniectomy, and then I will start the dose of anticoagulation after that.
Okay, thank you very much. I'd like to close the session here. I'm very, very thankful to both of our speakers, Dr. Elyar and Dr. Fawaz, for taking out the time and for sharing really challenging and very interesting cases. I apologize again to the audience. We struggled with the sound system today. We will hopefully try to fix things before our next grand round. And please fill out the evaluation so we get this feedback as well and we can improve our services for you. Thank you very much, all of you, and enjoy the rest of the evening. Thank you, Dr. Elyar. Thank you, Dr. Fawaz, for taking.
Thank you, Dr. Maria, for this very hard presentation.